Hi everyone, welcome to my channel. Today's topic is white blood cells or WBCs. We also call these cells leukocytes. Okay, this is very important topic for practical aspect actually. So in this video we'll study about classification of WBCs, what are different morphological aspects, how we can identify them, and different conditions where these cell count can vary. Okay. So normal count of WBC is 4000 to 11,000 cells per mm cube. Fine. Classification of WBC. WBCs can have granules or not. If they are having granules, it's granulocytes. Okay, granulocytes are further of three types: neutrophils, eosinophil and basophil. So how you will identify neutrophils? If the granules are pinkish in color and fine granules, okay, very small size, and then it's neutrophil. If they are coarse granules, right, so it can be eosinophil or basophil. If there are reddish granules, coarse reddish granules, eosinophil, which are not on nucleus. Basophil, the coarse granules which are blue in color, okay, and they are covering the nucleus. Fine. So this is all about granulocytes, right? Coming to agranulocytes, when you don't have any granule in the cell. Fine. So agranulocytes are of further two type: lymphocyte and monocytes. Monocytes are the largest cell which are horseshoe shaped nucleus. So cell have a kidney shape or horseshoe shaped nucleus. Lymphocytes can be of two type: small lymphocytes and large lymphocytes. So lymphocytes are basically having round nucleus, having high nucleus to cytoplasm ratio. What that mean? You will look a rim of cytoplasm around the cell here. Okay, small and large lymphocyte you can identify basically comparing the cell size with RBCs. So if they are comparable to RBCs, it's small lymphocyte. If not, they are comparable to WBCs, it's large lymphocyte. Okay, we'll see all the characteristics. It's just classification. So functionally we also see lymphocyte as of two type, because physiologically they have two functions in immunity: B lymphocyte for humoral immunity and T lymphocyte for cell mediated immunity. Then various granules are present. So granules of neutrophil, if we see, okay, there can be primary granules, secondary granules and tertiary granules. Primary granules are also called azurophilic granules, basically bacterial permeability increasing. Fine. They are having acid hydrolase enzyme, myeloperoxidase enzyme. They are full of acid hydrolase and myeloperoxidase. Okay, so it's just composition you have to see. Primary granules have acid hydrolase and myeloperoxidase. Secondary granules have gelatinase in them. They have lysozyme, alkaline phosphatase, collagenase or histaminase. Okay, tertiary granules have they basically store granules. During chemotaxis they release these granules. So ultimately whatever granules these cells are having, they help in phagocytosis. What part of pathogen they can lyse, that is the specialty of granules. Okay, so depending on, like collagen, it destroy collagen, they are secondary granules, right? So they release during chemotaxis. The tertiary granule, they are released during chemotaxis to attract various other phagocytes. Okay, then proteinases, gelatinases help in cell migration via basement membrane lysis. Okay, so these are some granules. Granules of eosinophil are of two type: azurophilic granules and specific granules. Azurophilic granules having acid hydrolase and enzymes, and specific granules have peroxidase, neurotoxin, histamine, cathepsin and collagenase. Let's just see morphological aspect, how we can identify the cells. So neutrophil, the major percentage 50 to 70% is neutrophil, 10 to 14 micrometer size, 6 to 7 hour is the lifespan, and if you see, they are having fine granules, okay, and multilobe nucleus. Coming to eosinophil, which are 1 to 4%, 10 to 14 micrometer size, and lifespan is 8 to 12 days, and if you see, it's brick red coarse granules are there. Can you see that? Can you compare the granules of neutrophil and eosinophil? They are very coarse and they are very fine, right? Then coming to basophil, they are less than 1%, 10 to 14 micrometer, and few hour to few days is the lifespan, and purple blue coarse granules are present, which are present over nucleus as well. Then comes his lymphocyte, which are having percentage of 20 to 40%. This percentage is high in children, and the large lymphocyte is 10 to 14 and small is 7 to 10. So lifespan is weeks to years, and nucleus to cytoplasm ratio is high in these cells. Small lymphocyte is comparable to RBC size. Okay. Then is monocyte. Monocyte is 2 to 8% and size is 14 to 18 micrometer. This is not percentage, this is micrometer, sorry. And the nucleus shape is horseshoe shape or kidney shape. Okay. So this is largest cell. Okay, coming to functions of WBC, neutrophils and monocytes are very important for our immunity. They are phagocytic in function. Neutrophil is first line of defense and monocyte is second line of defense. Monocyte become macrophage and enter into the tissue for whole over life and remain there for whole life, like Kupffer cell in liver, microglia in brain, dendritic cell in GIT, PAM in pulmonary alveolar macrophages in lungs. Okay. Lymphocytes, when we talk about, main part of cell mediated immunity is the T lymphocyte and humoral immunity is the B lymphocytes for antibody production. Eosinophils are important for mild phagocytic activity they are also having, but they limit allergy and parasitic infection. That is the most important function of eosinophil. They also provide mucosal immunity in GIT, urinary tract and respiratory tract. Coming to basophil, they basically increase release of heparin, histamine, serotonin during allergic reactions and having mild phagocytic activity as well. At last, let's see the conditions of variations of leukocytes. So, leukocyte when increase, the term is leukocytosis. So, normal range is 4000 to 11,000. So, more than 11,000 is leukocytosis, right? Decrease in leukocyte count, which is leukopenia. Okay, you can be asked these terms. Less than 4000 per mm cube is leukopenia. Fine. Then leukocytosis, if for example you are doing only WBC practical, WBC count, okay, the total leukocyte count, then you can be asked only this question, like overall leukocytosis and leukopenia and the condition. Fine. In that scenario, you can answer this way. So, physiological leukocytosis can be in infants, post-meal, stress, exercise, pregnancy and childbirth. Pathological can be because of any acute infection, burns, hemorrhage, malignancy, surgery or myocardial infarction. Leukopenia can be physiologically, it's rare. After starvation it can occur or extreme cold. Pathologically in typhoid fever, protozoa infection, viral infections, X-ray and some chemicals causing bone marrow depression, causing less synthesis of WBC. Okay, so this you have to answer if specifically you have only total leukocyte count. If DLC you are doing differential leukocyte count, you have to answer variation in each type of cell. Let's see how. So first is neutrophil. Okay, if neutrophil is increased, it's not neutrophil cytosis or something like that, it's neutrophilia. Okay, and penia is same, neutropenia. Fine. So neutrophilia can be physiological during exercise, pregnancy, menstruation, lactation or post-meal, right? Pathologically acute infection, hemorrhage, surgery, burns, hemolysis and pneumonia. So there can be neutrophilia in this condition. Neutropenia is basically neutrophil count is less in children. Children have basically more or high lymphocyte count. Fine. Otherwise, pathologically if we talk about typhoid fever, viral infection, B12 deficiency and bone marrow depression, they are conditions of neutropenia. Coming to next cell, eosinophil. Eosinophilia occur because it's important for allergy and parasitic infection. So obviously in these two conditions only eosinophilia occur. So in asthma, hay fever, skin allergy and parasitic infection, right? Eosinopenia can occur in Cushing syndrome or administration of some steroids. Basophil, if we talk about basophilia, it basically occur in viral infections, chicken pox or influenza and during allergic condition to release histamine. And basopenia, decrease in basophil count is basically on X-ray exposure, drug induced or stress. Lymphocytosis, if it's increased lymphocyte count, lymphocytopenia if it's, or lymphopenia sometime, it's decrease in lymphocyte. So lymphocytosis physiologically in children, pathologically during chronic infection like TB or viral hepatitis. Lymphocytopenia in bone marrow depression, AIDS, steroid treatment, radiation exposure, or Hodgkin disease. Monocytes. Monocyte increase in count, monocytosis. Decrease in count, monocytopenia. Okay, increase in monocyte count in TB, malaria, viral infection, Crohn's disease, or Hodgkin disease. Monocytopenia, prolonged use of immunosuppressant, hypoplastic bone marrow, and AIDS. Okay, then so we have done the complete classification and variation. So you can be asked two questions. What is leukemia? So leukemia is malignancy of blood where marked increase in myeloblast cells increase. It can be myeloid or lymphoid, any series can be affected. Leukemia can be classified based on this assumption that which series is involved. So myeloid series, if it is involved, they can be AML, acute myeloid leukemia, or CML, chronic myeloid leukemia, right? Acute myeloid leukemia, so it can affect 15 to 40 year age, and there can increase in myeloblast cells are there. Chronic one can be associated with anemia, fatigue, or weight loss, and chromosome translocation. Up to 1 lakh per mm cube can be the RBC, the WBC count. Okay, acute, then we are talking about lymphoid series, same acute and chronic, lymphoid leukemia. Okay, lymphocytic leukemia, it's associated in children or young adults, it can occur, and there are increase in blast cells and present with fever, anemia, or infections. And here chronic lymphocytic leukemia, it's basically in old age and increase mature lymphocyte occur here. So can you see here in CLL there are mature lymphocytes, and here you can see the myeloblast increases. Okay, so you can be asked what is leukemoid reaction. You can be asked what is leukocytosis, leukemia, and leukemoid reaction. Sometime you can be asked this question during your practical. So what is leukemoid reaction? Increase in WBC count, which is physiological response to stress or infection. Okay, where stimulation of hemopoiesis occur, increase in immature cells will be present. Cause can be increase in hemolysis, chronic infection in kids, carcinoma breast, or carcinoma kidney. Increase leukocyte alkaline phosphate, which is not present in leukemias, can help to differentiate it. So that's all about WBC, its classification, recognition factors, and various variations in WBC and the condition. So all the viva questions we have completed here. I hope point is clear. You understood the topic. If you have any query, you can comment below. Stay tuned for next video. Thanks for watching, guys. Bye bye.